Hello, thank you for joining us today. I'm Shelley Fold-Nasso, CEO of the National Coalition for Cancer Survivorship. Our mission is to improve the quality of cancer care for everyone touched by cancer. And we do that by educating and empowering cancer survivors, caregivers, and advocates, and by advocating for changes in the cancer care system to better serve cancer survivors. This webinar today is part of our Survivorship Champions program for clinicians and researchers who are interested in improving care for cancer survivors. Survivorship Champions is a community with information exchange about best practices, lessons learned, and effective models of survivorship care. I want to thank Veronica Paniotu, NCCS's Advocacy and Programs Manager, for planning this webinar, along with the NCCS team who works behind the scenes to make it happen. I'm thrilled to introduce you to Dr. Pamela DeGuzman. I knew I was going to say it wrong, I'm sorry, who will present on her work, a nurse-led care model to improve access to rural survivorship care. Pam is an associate professor of nursing at the University of Virginia School of Nursing. In her bio, she says, "I am passionate about teaching nursing students the leadership, business, and communication skills they need to change the way patients are treated through health systems theory and public health systems research." Thank you so much for joining us today, Pam. We really look forward to your presentation. And just for the audience, I want to let you know that we will be sharing her slides afterward, and feel free to ask questions in the Q&A tab during the presentation, and we'll get to as many questions as we can after her presentation. So I'm thrilled to turn it over to you, Pam. Thank you so much.
Thank you, Shelley, for that nice introduction. And I have to tell you, I'm just so thrilled to be able to be here and talk about this work. Because it's my understanding that a lot of the people that come to these sessions are nurses, and so it's really a delight to be able to present to people who are doing this work at the point of care, and to be able to get questions and any feedback from them as well about this work. Again, I am Pam DeGuzman, and I am at the University of Virginia, where I research access to care, usually for vulnerable populations and typically rural populations. Just a few acknowledgements. Our work was funded by the UVA Cancer Center. I realized I put this slide together that I probably shouldn't have put the basketball up, because it's my understanding we didn't actually make the NCAA, but I don't follow basketball that closely, so hopefully you'll forgive me. But you know, all the people that are on this slide, we could not have done any of this work. It really was honestly a cast of thousands that went into this, including so many people from our telehealth center, our clinical cancer center. We really worked with people at the point of care, because it's very important for me that that my research is very translatable to the practice setting. So I'm just going to start with a little background about rural cancer survivors. And I do want to just make sure, you know, we're all sort of using the same definitions. And of course, Fitzhugh-Mullen back in 1985 introduced those three phases of survivorship. The acute phase, which of course begins at diagnosis and extends through active treatment. Then the extended survivorship phase that begins when active treatment is over, and then continuing sort of as people determine, you know, what is their new normal, and then finally permanent survivorship. And in this presentation, I'm referring mostly to the extended phase. So from the time that treatment is over until as people are sort of adjusting and trying to make sense of their life post-treatment. So for those of you, and probably many of you have experienced working with survivors and patients that come from rural areas, you know that a lot of people are traveling very long distances, particularly to get highly specialized cancer care from regional settings. And this is, you know, what happens in Virginia, where we're not even, you know, one of the biggest states that I can imagine people probably come from many hours away, but people will travel up to 6 hours to get care at our cancer center. And often they have to maybe stay overnight, or, and I would imagine a lot of places, I know in Australia, for example, people have to actually move into temporary housing to get their treatment from a regional center. And so they're doing that for active care. And so when it comes to survivorship care, they may not want to make that long trip as, again, to get that kind of care. And so we do like to return their care, of course, to their primary care provider in their community where they live. But we know that PCP's education is very limited in survivorship. And not only that, but in rural areas, you might have a rural PCP who has this limited education, but at the same time is dealing with people that may have survived a variety of cancers. So they might be dealing with survivors from a half a dozen or a dozen different cancers. And it's really hard to stay current and understand all the nuances of survivorship for each of those different types of cancer. And probably related to both of these things, we do know that rural cancer survivors do have lower survival rates once they've been diagnosed, and that they have a lower quality of life as well. And as I mentioned, we also know that once active treatment is over, that rural survivors are less willing to travel for that supportive care than they were for treatment. This makes a lot of sense. When you're in active treatment, you're worried about just surviving. And so you're willing to make that extra trip or those extra trips to get the best care. But then once you're in survivorship, you want to kind of return as much to your life as possible and don't want to be traveling unless it's absolutely necessary. And we also know that that travel distance is independently associated with worse quality of life during survivorship, and also what we call more unmet needs. And in this case, unmet needs refer specifically to unmet needs of survivorship. And that means these are needs that are related to their cancer that they would like to be addressed, but have been unable to get addressed. And that's one of the things that we measured in our research, and I'll refer to that a little bit later. So the first study that we did in this area was back in 2015. And I've put the citations in here of the work that we've published so that if people want to go back and look at it after, you have all the information. And this study was published in the Journal of Oncology, Navigation, and Survivorship, which I'm sure many of you are familiar with that wonderful journal and it's in the organization. And we looked just at UVA that has, UVA serves patients from all over the state. So we have a catchment area of rural, urban, suburban. And we just wanted to find out, what do people know about survivorship, how to take care of themselves when their treatment is over. And what we realized pretty quickly was that our rural survivors and those that were traveling from a really long distance away did not know how to access any survivorship resources once their primary treatment was completed. And that was in light of a cancer center that was, we have a large cancer center, we have enormous number of resources available for people in active treatment and in survivorship. So this was kind of eye-opening to us to realize that rural survivors didn't know that these resources were available. But the other thing that we realized, and those of you that work with rural survivors, this may sound very familiar, is that rural survivors were not always having their supportive care needs recognized and addressed during treatment. And the reason seemed to be something that we had created ourselves, which is when people are traveling from a long distance away, particularly if they're low income, which our rural survivors and patients often are, we want to minimize their going back and forth as much as possible, and really want to minimize, them incurring the costs of an overnight stay if possible. So we do something called appointment stacking, and that's just what we call it. It's probably done in a lot of places where we essentially try to schedule every medical visit at the same time. So they might in one day see hem-onc, the surgeon, have their scans. And because we're sort of stacking all these appointments in the same day, a lot of the supportive care services tend to be a little bit more deprioritized, and there's not as much attention paid to them because we have to ensure that they get these medical treatments and medical care and visits while they're there for that one day. And what we thought was this may be leading to, because we're not identifying these problems and these issues and unmet needs during active treatment, that into that extended phase of survivorship, it just wasn't being picked up and addressed. And so we knew that, we wanted to look at a way to address that. So the question we came away with was, how can we connect our rural survivors with that appropriate care that we had available once treatment was concluded? The next study that we did, again, with our rural population, was we looked at survivorship care plans. And this was published back in 2017 in CJON. And we wanted to understand, if our patients were, using their survivorship care plans, how they were using them. And we did this study with breast cancer survivors, because we knew that at the time this group had their survivorship care plans rolled out, and that they were getting them very consistently through our nurse practitioner in the clinic. And probably the most surprising thing, it doesn't sound that surprising anymore, because we know that survivorship care plans, that there's a lot of difficulty in getting them implemented. But one of the most surprising thing was when we asked people, can you tell us about your survivorship care plan? Well, first of all, they didn't even know what it was, which is maybe not that surprising, because, that's maybe just jargon and terminology that we use. So we would ask them, did you get any information about how to take care of yourself now that you're in survivorship? And one of the women in the study said, oh yeah, that pile of papers. And as nurses, I think we can really understand this, whether we're discharging patients from the hospital or from active treatment, we give them a stack of papers. And I think in a lot of cases it goes home, and it's something that people aren't looking at unless they need something later. And so this woman just said, oh yeah, I have that pile of papers, but really hadn't looked at it. The other thing that they told us was that the survivorship care plans we were delivering at that end of treatment appointment, we were transitioning them into the extended phase of survivorship. And they told us that at that point, they really were focused on having survived, not what was coming next. And again, this probably, shouldn't have been surprising to us, because we do obviously put so much emphasis on you're done with treatment, you survived it. And so, we thought, well, they're not really hearing all of this about survivorship care at this point where they're celebrating, understandably celebrating that they have finished this aspect of their journey. And then the final thing that we really noted was they were very informed about their medical aspects of survivorship. They could recite when the next mammogram was. I remember one woman even told me, I know my next mammogram is on this date. And we do, of course, focus on the treatment plan in the survivorship care plan delivery. And they knew what they had done, what they had gone through, and when they were supposed to take their medicine and come back. But they knew very little, in some case, nothing at all, about other aspects, more supportive care aspects, what to do if they were having financial difficulties or emotional difficulties, or just any other kind of difficulties that we had resources for. So we had two things that came out of this research. First of all, we thought, we wondered if survivorship assessment and education really needed to occur at a time that was distant from that end of treatment appointment, so that we could close out the visit, close out the treatment, and then go back and see how are people doing, and then really reinforce that education and all the resources that were necessary once someone had had time to kind of go home and reflect on being a survivor and what that meant to them. And then the other thing we thought is, should we be uncoupling this from the medical aspects of the treatment? Because the medical aspects are so important and so paramount throughout. But when people are focusing on that, we thought maybe they're not able to focus as much on some of the more psychosocial or supportive care needs that they're going to have, that we know that they have as survivorship sort of progresses through that extended time period. So we developed this hypothesis in our research, which was that delivering survivorship care to rural survivors at the end of treatment, after the end of active treatment, could reduce the unmet needs, those needs of that were related to their cancer that they were experiencing but not having getting addressed during extended survivorship. So we thought, let's see if we can deliver it at a time distant. But you'll recall, if you're a rural survivor, you don't want to come back in for your any type of supportive care. You're less likely to want to do that travel for supportive care. So instead, we decided we would develop a telemedicine intervention. And we called this intervention CARING, which stands for Comprehensive Assistance, Rural Interventions, Nursing and Guidance. And CARING is a telemedicine delivered nurse-led visit for cancer survivors that we would deliver several weeks after treatment completed. We thought it was really important, or certainly I thought it was very important for this to be a nurse-led visit, because delivering this is very much in the scope of practice of an oncology nurse, and a nurse could do this. I think in a lot of places, nurse practitioners do this, which is also, a great provider to do this, but actually this is all within the scope of an RN. And so I wanted it to be delivered by an RN. The intervention has three main components: assessment. And for assessment, we used the NCCN distress thermometer and problem list, and we amended it a little bit. I'll talk about that in a minute. But we used that tool to be able to understand and really target what areas of distress survivors were having. And then we would follow that with education, either education specifically about the distress they were having and what resources were available, and also reinforcing those aspects of the survivorship care plan that they had received at the end of treatment, but maybe just didn't realize because they hadn't been able to really understand all of that at the time. And then finally, the final piece was for those issues that people were having distress, but education wasn't really addressing it, we would refer them. And we referred to any of the stuff we refer our patients to, social work or financial counseling, physical therapy, you name it, whatever they needed, that referral piece was the end, so that they had extra support for some of those issues that were causing a lot of distress. Well, of course, we started this before COVID, but since COVID, I think we all know how difficult it is to do telemedicine in rural areas. And of course, we also realized this beforehand. I think we launched this in 2019, and we already knew at the time that there were these known barriers to telemedicine in rural areas. And I've put in this graph, just put on my laser pointer, that you can see that the Pew Center, every year they track from 2000 and so far through 2021, what % of adults have home-based broadband. And as you can see, even in 2021, rural is only at 72%. And of course, back then it was much lower. And so we knew not everybody was going to have broadband. And, you might look at this and think, well, it's not that much lower than urban or suburban. But if you think about where you live, and I think about where I live, which is an urban area, it's a small urban area, but it's urban. If I don't have home-based broadband, there's a dozen places I can go within walking distance. I can go to Starbucks, a different coffee shop, the library, McDonald's, all these places I could go to get broadband. Well, you can't do that in a rural area. You might have a library as an option with broadband. And before COVID, libraries didn't have as much broadband as they have had since. So we knew that this gap was probably a lot bigger than what it looked like there. The other piece is that, we think, oh, even if people don't have equipment, they have smartphones. Not necessarily the case. People in rural areas are also much less likely to have smartphones. And those of you that either live in rural areas or work with patients in rural areas know that a lot of people still have flip phones to this day, or even just a landline. So we had to make sure they had broadband and that they had the right equipment. And usually if they had broadband, they had some kind of a computer or device that they could use to connect to the internet. So because we knew this, we had a lot of options for how people could connect, because we did not want their lack of broadband to be a barrier. So the first thing we did was we assessed, do they have the ability to connect via their home-based broadband? And if the answer was yes, then we would have them do the home visit over telemedicine with their own equipment. And if not, we gave them two options. One was the UVA at the time had over 100 sites. I think it's probably close like to 150 or more now, but they had over 100 sites where somebody could go and potentially connect through like another clinic, or they could just, use the equipment there. And so we did have, I think, of the 30 people that went through the intervention, I think 2 or 3 actually traveled to another site. But what was more popular, and you can imagine, cancer survivors may not want to travel, is that we would loan them an iPad that was loaded with a data cellular signal so that they can connect to it over. We loaded it with Verizon, which is very common, that you can connect in rural areas in Virginia. And so that they could do the visit. It wouldn't cost them any data. If they were using a phone, we didn't have to worry about them having a smartphone. And so most people did either this option 1 at home with their own equipment, or option 3, where we mailed them the cellular enabled tablet to do the visit. So I'm just going to segue a little bit to talk about head and neck cancer, because we did do the study with head and neck cancer survivors. And any of you that have worked with head and neck cancer are probably very aware of how difficult a cancer this can be for people. Not that any cancer is easy, but as you can see from the picture, head and neck cancer affects very visible areas of the body. And so virtually all patients get surgery. And so you've had surgery on some very visible area. Some people are left with speech difficulties, drooling, swallowing difficulties, difficulty eating. There's just a variety of things that make it really difficult in very ways that impact people's role functioning or appearance or how they feel about themselves. And probably that it's not perhaps surprising that it does have the second highest suicide rate of all people with different types of cancers is head and neck cancer. But possibly also related to that, research has shown that head and neck cancer survivors, 2/3 of them have unmet needs during survivorship. And one study that looked as far out as 5 years found that an average of almost 4 unmet needs per person for cancer survivors from head and neck cancer. So these are people who are dealing with a lot of stuff and they're not getting help for it. And we also know that head and neck cancer unmet needs were significantly impacting their quality of life. So we chose to work with this wonderful group of patients for our study. And this is a picture of Alan, who's the nurse. He, at the time, was the nurse working with the head and neck cancer team. And so he delivered the intervention for us to all 30 patients. And you can see this is actually a mock-up we did of the intervention. This is not an actual patient visit. This was for our TV station, but I love the picture. And actually this person working on it, she was on my first slide. That's Ivy Hinton. She's a member of our research team, but also is very proud as a cancer survivor and was very happy to work with us on this and be in this photo. But you can see Alan on there, and he's in the clinic because this was, again, back before COVID. And he has the intervention here on his screen, and he's talking to Ivy there. And here we have, you probably recognize a snapshot of the distress thermometer and problem list. And of course, the distress thermometer, you go through all of these different things that might and often do create distress for people who are cancer survivors. And typically what we do is just have people check yes or no, and then they rate it one number on the thermometer. And if it's above a 4, we consider that to be high distress. What we did and what Alan did for the patients is we really wanted to target these areas, and we knew that this was a discrete visit. So for each time they said yes, he would run through it with them, and each time they said yes, he would ask them to rate that one as a 0 to 10. And that way, over the course of the visit, he could prioritize with them and really kind of use that as a launching point to understand more and ask questions and just really take a deep dive into that assessment with them so that he was able to provide the correct education and referral for the patient. So now I'm going to switch gears and talk about the 5 major findings of this work. So the first finding, which again, probably if we had done this after COVID wouldn't have surprised us, but it really surprised us. And that is that digital inclusion impacted our ability to deliver telemedicine even when those broadband challenges were overcome. So let me unpack that a little bit for you. Digital inclusion is something I had never heard of before we had our findings. And I was talking to a professor of media studies, and he said, that's digital inclusion. That's what you're running into. Digital inclusion means just because you give someone the equipment, as we did, we mailed them a tablet, that had a signal, they were able to connect. Digital inclusion means you also have the digital literacy and the digital skills to connect. And what we realized was without that, it was not really possible we could actually connect them to the telemedicine intervention. It turned out to be not a great fit for that population. We actually, in some cases, caused them distress because they would get so anxious about connecting and had so much trouble. And it makes sense. If people aren't regularly using the equipment, they're not comfortable with us. And I think that was our very urban sort of focused view that, people just understand how to use this equipment. And it was such a huge learning curve. So what we found, and you'll remember that most people did option 1 or 3, but when they did these at home, if they were unfamiliar with the technology, it sometimes led to increased, seeming like they were having actually increased distress, which is not something you want to do when you're trying to reduce somebody's distress. So we realized pretty quickly we were going to have to find another solution for that. And even though I'm not talking about it today, this led to a whole program of research that I now have in looking at implementing telemedicine in rural public libraries, because that's another solution that because in a library, you have the equipment now. Since COVID, almost all libraries have high-speed broadband. And then they have most importantly, they have librarians who are who are information access specialists, and they can help troubleshoot some of the stuff. And it is being implemented in several places across the country. Here's just a real great quote from one of our rural survivors who, just to show how much distress she's having. She said, it was just not connecting. And, that's just nerve-wracking when something doesn't work and you're trying, because people really wanted to talk to the nurse and they really wanted to go through this intervention. And it was very stressful to her that it didn't work. And then we did end up publishing this back in 2020 in Journal of Cancer Survivorship. So the second finding, again, which surprised us, was that rural cancer survivors that were having high distress often refused further intervention. So 90% of the 30 survivors that went through the study had at least one area that they rated above a 4, which counts as, of course, high distress. And of those, remember I said the nurse didn't necessarily refer everybody, but if things were not managed during the visit, then he would refer them for further support. And that happened about half the time. And in fact, our intervention, when we tested it against a control group, was associated with 13 times chance of getting a referral. So we knew we were getting at least that far. We knew we were identifying people with high distress. And then when they needed it, we were able to refer them on further just by using this targeted distress screening. But when people were offered a psychosocial referral, fewer than 1/3, in fact, about 28% accepted it, which means everybody else who had self-identified with high distress and were offered to talk to somebody about that further, they said, nope, no, thank you. And these results were also written up in Journal of Cancer Survivorship last year. So we started to think about why that was, and we conducted another study to kind of understand. And, we were we were using a sample of rural survivors. So we were thinking about, we knew that in rural areas, there can be a lot more stigma with accepting mental health. That's been very documented in the literature. So we thought maybe it's something to do with that or other rural social norms. And we did do a study and found that their reluctance to accept psychosocial help was highly aligned with what we have seen in the literature as being rural social norms and what you've probably experienced as well. So when explaining their reasons for turning down any further help, people would minimize their distress. And remember, these are people that had identified as having high distress. They had discussed it with the nurse. They had described it to the nurse. But then when we went back and asked them, they're like, well, maybe, it really wasn't that big of a deal. Or, oftentimes we would hear people say, well, what I had going on isn't as bad as what other people have. They also described stigma associated with seeking help. And they also described not wanting to talk to people usually outside their immediate family. People, a couple of men, I'll just talk to my wife about that. Although I don't really talk to her that much anyway, but that, was clear just drawing that line there. And this was a great quote from one of our survivors who said, I don't want to learn the appearance that as I'm getting older, I'm less able to handle my situation. And that's a protection on my part. I try not to view anybody else that way, but I tend to view myself more critical. She just didn't want to get the help because she just would not feel good about herself if she had accepted that help. And this paper hasn't been published yet. It's currently still under review, but it is available, I think, as a preprint through the Journal of Medical Internet Research, if anybody is looking for that. So our fourth finding was that despite all the telemedicine difficulties, despite not wanting to talk to somebody else about their distress, the rural survivors were willing to talk to the nurse. I mean, they talked to the nurse when Alan went through the distress screening, and then he asked them, they opened up and they did discuss this distress quite openly with him. And you can see a little bit of that in at the end of each intervention, we conducted what's called the telemedicine satisfaction and use questionnaire, because we just wanted to see, did people like using the equipment? And this is just a series of statements, and people just score it from 1 to 5, from like not agreeing to strongly agreeing, when 5 is the most agreement. And as you can see on here, those that are ranked the highest are my nurse deals with my problems, my nurse engages me in my care, I can explain my problems well enough during the video visit. People were absolutely willing to open up and share that information, despite not wanting to talk about it to someone else and saying that, they didn't feel comfortable with that, but they felt comfortable talking to the nurse. And in fact, the survivors explained that was the biggest benefit of participating in the visit, was being able to speak with the nurse. One survivor said, I appreciated the nurse taking the time to ask me the questions and, identifying with my needs. It's good to have someone ask these kind of questions. And then the last finding, remember we talked earlier about unmet needs. We did find that a telemedicine intervention with the nurse can reduce survivors' unmet needs, particularly their emotional needs. And so we used a scale called the SUNS, which stands for the Survivorship Unmet Needs Scale. It's specifically designed for cancer survivors. And we administered it before and after the intervention. And then we did find that it changed. So as you can see here, the mean for each one, a negative number means that it went down, which meant an improvement or fewer unmet needs. And this was on a scale of 1 to 4, with 4 being the most unmet needs and 1 being the least. So you can see overall, it went down by about 0.24 on that 1 to 4 scale. But if you look at this, coping, sharing, and emotional needs went down by about 0.4, which on a 1 to 4 scale is, about 10%, which is considered clinically significant. So it did seem like something was going on here where, between the patients opening up to the nurse and participating in the visit, that it did somehow provide some outlet for them, either education or just talking about their issues. It was beneficial. And this paper has been accepted, but it's in Oncology Nursing Forum, but it has not come out yet. So that will be coming out soon. So just to kind of sum up these conclusions, and I think that there are things that people can use today in their practice to think about. That when you're doing telemedicine and you're connecting to rural survivors or really anybody, sometimes older people experience difficulty with technology, you should consider not just broadband accessibility, consider also, are they comfortable with the skills to connect? And if not, one of the options you can do is suggest, for them, or you can help them call a library, that the library may, in a lot of cases, are able to help them and can accommodate them with a private room, or if they need equipment, that's always an option if people are having just difficulty and don't feel comfortable connecting over telemedicine. We do know that rural survivors can benefit from discussing their distress with a nurse over a virtual connection. I think that we've always known that survivors can benefit from talking to nurses, but I think this is the first study that's looked at this over a virtual connection, and we were really glad to see that survivors benefited so much. But we have to keep in mind that social norms might prevent their willingness to talk to other members of the healthcare team, but they will talk to us. They will openly, or at least, may openly discuss their distress with a nurse. And then we know, or, we have some indication that targeted identification and discussion of distress can improve those unmet needs. Now, this was a very short time period. This was a one-time intervention. So there's a lot more we need to learn about that, but our results do seem to indicate that this can be something very beneficial to patients during the survivorship period. And so a little bit about our next steps, because, with research, it's always, the conclusions are always more research is needed, and it is the case with this as well. So one of the lingering things we have is looking at referral uptake, because we have, wonderful, as you probably do in many regional cancer centers and large cancer centers, wonderful oncology-specialized social workers and counselors that we want to be able to connect people with. And so we want to improve what we call that psychosocial referral uptake. So one of my collaborators is a psychologist out at Iowa State University, and he specializes in stigma. And they have developed, not with survivors, but with college students, a mechanism for improving uptake to mental health services for people who do feel stigma related to seeking those services. And we are in the process of testing that with rural survivors. And that intervention is a self-affirmation intervention, meaning that it's an exercise that's very brief, where we just talk to people and we ask them a series of questions like, have you ever done something helpful for a friend in need? Or have you ever, been kind to a stranger? Questions like that, where if you get enough yeses to that and they talk about that, people feel very self-affirmed. And the idea is that when they're feeling very positive about themselves, then the threats of that can go to your ego by, asking for that help outside can be lessened. That's the idea of it. So we're going to test that and see how it goes and see if this improves uptake. The other piece is, I didn't really mention that much, is even that those 28% of people who needed a psychosocial referral and said yes, when the social worker connected with them, which was usually over the phone, a lot of times people would resort to those behaviors of minimizing distress and saying, oh, I don't need help. And so we weren't actually able to connect that many people with the next steps of maybe finding a support group or a counselor. So this time, what we're doing is we're going to incorporate a warm handoff to the social worker. So we're doing just a small pilot study in the clinic at the patient's first follow-up visit. And when we do that, if they say that they're amenable to talk to a social worker or connect with someone, we're going to page that social worker immediately, and they're going to come down and talk to the patient right then and there. Or we're going to hand that off, describe what's going on right then and there, so that we know that people don't get sort of lost during that care transition. So with that, I am going to close out, because I know I've just given you all a ton of information, and I know we would said we would leave some time for any question or discussions. I thank you all so much. It was really just such a pleasure to speak to everybody today.
Thank you so much, Pam. We do have some questions. I will say that your presentation was excellent, because as I was writing down notes and questions as you talked, then you would answer the question in your next slide. So it was wonderful. But there were a couple questions about the scale, about assessing survivors' unmet needs. Can you tell us a little bit more about the name of that, and is there a link to it that people can find that? Is that an instrument out there that other people can use, or was that your own?
It was not my own. It was developed in Australia, and you all may know a lot of rural research and rural survivorship research in particular is done there, because they have a lot of rural areas. And the person who the last name is Campbell, I can't remember her first name. I think it's Sharon Campbell, and it's called the Survivors Unmet Needs Survey. So it's SUNS SUNS, and then we use the short form, because the long form is like 89 questions, and there's a short form that I can't remember how many questions, but it's much shorter. So we used the SUNS SF by Campbell. Okay. And all I did to use it was, and I think it says this on it itself, is you just have to ask her for permission, and she says yes. But I think if you even Google her, I can't remember what university she's at, but I'm pretty sure it's Sharon Campbell, and she's just said, yep, you can use it. But
so Veronica will try to find that, and if she finds it, she'll post a link in the chat for it.
Okay, and Veronica, and I can probably send it to you as well.
Otherwise, we can post it with the webinar, a link to it. Okay, great. Thank you so much. So, all right, there's a bunch of questions. So, was stigma associated with the mental health care correlated to older patients who may fear loss of independence?
So we did not look at age in terms of it being correlated, but I can tell you from, I believe from other research, it is more correlated with older populations. I think that is, I think older populations, men, people in rural areas are all usually have higher stigma in general with related to mental health. So I would expect to see that. We just didn't have enough people to really test that and see that.
Yeah. Okay. And I know you're testing the warm handoff, but what are have you thought of other potential interventions to try to help reduce that reluctance to accept the further help?
Yes, we have. And, it's the frustrating thing about research. You can only kind of test so many things at once. But one of the things, and we saw it, even though it wasn't really statistically significant and we didn't really test that much for it, we know that men are more likely to have this stigma. And one of the things we thought about was, do we need to have this also be a caregiver, a sort of a dyad, and bring the caregiver in there? Because if the spouse is there, is that going to help as well? Whereas in this intervention, we gave people the choice if they wanted to have somebody else there with them. But I think particularly with men, that might be helpful as well.
Okay, great. Thank you. So another question is, what are your thoughts on social workers delivering the distress thermometer and the telemedicine care, like what the nurses are doing now, or do you think nurses are better suited for it?
I mean, I think I will admit, I don't know that much about what social workers are allowed to do, or if that changes state to state, but I feel like assessment is that's so much, what nurses can do, and they can assess the physical and the psychosocial, whereas I'm not sure if, because a lot of the stuff, we didn't really talk about it here, but a lot of the stuff was physical assessment as well, in terms of if people were having pain, if they were having, maybe they needed some physical therapy, or they were having lymphatic issues. and what's interesting is they accepted all those referrals, right? That was
Right.
never an issue. But I don't know if would the social worker necessarily be able to do that. And that's just, I just don't know the answer to that. But I feel like from my knowledge of nursing, this fits pretty squarely in with nursing. But I also know that, you know, on the one hand, nursing is already very overburdened.
Mhm.
And I'm kind of answering a little bit of another question that you didn't say, but they're overburdened. But at the same time, I feel like this is the kind of thing that's very rewarding as a nurse. And, you know, it's, you're actually like, you know, able to help patients. And I think it's the kind of thing that nurses would, you know, would enjoy doing if they had the time to do it.
Yeah, and it sounds like too that that stigma too of, you know, they want to talk to a nurse, but then when you're talking about somebody else helping them, they may be a little bit less willing to accept it.
Yeah.
So it's potentially that could be more, there could be more acceptance to talking with
It-
a nurse.
I think that's true. And again, that's a whole, there's so many studies that we could do from this. Like we just don't have enough time to do it all. But how much is it, you know, that nurses are just so trusted?
Mhm.
You know, and something that I didn't mention, Alan was the nurse on the team or a nurse on the team, but he didn't see and know all these patients. Some of the patients were from other parts of the practice because, you know, that was something we're like, oh, is it because they knew Alan? And at one point, I think we had a couple patients that my doctoral student, who's also a nurse, had to do the intervention because Alan wasn't available. Like it didn't matter who it was, as long as it was a nurse. People were very, you know, whether they knew them or not. I think there's a trust. We know there's a trust, you know, with nursing, and I know with social work. That several people had said to me along the way, do you think it's because you're calling it a social worker? And we even changed the terminology to say, well, would you like to speak to someone? So it wasn't that, but I do think even social workers have told me this, that sometimes in rural areas, people think, you know, social worker is the person coming to take your kids away or, you know, something like that, like the wrong perception about what social work is. So we tried to kind of change the language, but there maybe isn't that as much trust in the profession as there is with nursing. All of that said, like I think there's a lot of this that social workers can do, and I love that we're collaborating with them on this phase of the project to understand that, you know, how we can incorporate them more.
Great. Someone asked about what about the physical needs, and you just mentioned that people were willing to accept referrals for some of the physical issues like pain and
Yeah.
lymphedema, things like that. So what, can you talk a little bit more about that?
Yeah, I mean, we didn't really look at it all that much, but it was, and I don't have the numbers in front of me, but probably about half the patients also had some type of physical issue. It was only about, I think, half of them that had some kind of a psychosocial issue, and I'm probably getting those numbers wrong, but I think it was close to the same. And I think part of that was, you know, I think that's what patients are used to doing when they go to you know, to their medical visits, is they're used to dealing with those physical issues and getting help for those physical issues. I think that we're maybe not incorporating the psychosocial, the
Mhm.
spiritual, you know, the financial, I mean, all those different pieces, role functioning as much into the visit as, you know, we could. And I completely understand the limitations. I mean, the healthcare is not, you know, a place where we have all kinds of time, right, to think about these things, particularly in the visit. But I think patients are just more open to that and discussing that and
Mhm.
getting.
Great. Okay, another question is that the digital access and digital literacy issues sound similar to issues faced by teachers and students in urban public schools. And so the question is, are you looking at what's happening with public schools and how their solutions to some of the digital inclusion issues?
That's such a great question. And actually, libraries, as you probably know, helped out with this too. I mean, libraries, my mind has been so open to like how amazing libraries are in just being the infrastructure in the public health and the educational system of this country. Because of course, during the pandemic, they all turned on their Wi-Fi, you know, 24 hours a day and made sure that it went, you know, beyond the walls so that people could drive up and drive to you know, the library parking lot in a lot of these rural areas and get connected so kids could do their schoolwork. There was a really interesting article that came out, I think it was in Journal of Family and Community Health recently, where researchers at School of Nursing in Washington State looked at kids' access to mental health care and how they weren't able to get those services in school also because of there are a lot of kids that just get those services in school, and during the pandemic they didn't have that access, and they had to find other solutions to that as well. So it's all kind of wrapped up in the whole thing of having limited broadband and how do we deal with that. And we're not really there yet, but I think we've at least uncovered a lot of the issues of both education and healthcare, where there are these people that are vulnerable to just not getting the services that everyone else has very easily.
Yeah. I love what you're talking about the library, because just having moved, I think I told you about this during our pre-call, when I moved to a rural area during the pandemic, and we didn't have broadband for a while, and the library was where I went. I sat in the parking lot of the library, or sat in the little private rooms, and it's amazing. And then they have, like as you mentioned, they distributed COVID tests and masks, and they have vaccination there. It's really such an important. It plays an important role in the community in a small town or rural area.
Yeah, I think they're very much community centers, and I think I live in an urban area, and so I have a library, but I don't I haven't gone there since my kids were little, and I took them to the library. But I don't think before this I realized quite how much they are the center of the community in these rural areas.
Mm-hmm. Okay, so another question is from cancer survivor and former nurse and NP, who said that another related area of inquiry would be looking at the effectiveness of nurse calls or telemedicine visits in between visits during active treatment. So like a call post-chemotherapy session to see how the patient is doing. She said she saw this as a gap where side effect assessment and supportive care could be really helpful.
I mean, I agree. I think that there's a lot of places where, nursing and NPs can be very instrumental in kind of, instead of sort of fielding the calls reactively, to be proactively and have places in the continuum of care where there are regular check-ins and assessing for these things. So we're not dealing with it all on the back end if we catch it at all.
Mm-hmm.
And, that question made me think of something else, if I could just mention, which is, telephone or telemedicine. One of the things that I've been asked is, well, why can't people just do this over a phone call? And there really is not a lot of research literature about what are the advantages of telemedicine versus just a phone call. And one of my library studies where I'm working with nurse practitioners to understand their perspectives on using telemedicine in the libraries, that is something that a lot of them spoke about, is that it is so, you get so much more information. And, people who do assessment know, being able to see the person, you can you can understand so much more about what's going on if you can physically see them. So I just wanted to mention that because you said telephone or telemedicine.
Mm-hmm. So I was really interested when you talked about that survivors are not necessarily ready for a survivorship care plan at the end of treatment, and that should be distant. And so I wonder if you could talk a little bit more about how distant should it be, and what do we need to do? I've heard from talked with some oncologists recently who said, oh, patients didn't want those survivorship care plans. So how can we, but yet it sounds like they need that information. So how do we optimize getting them the information they need when they're ready for it, or increasing their readiness for it or willingness to have that information and use it?
Yeah, so I think that's a great question. And I think it's an open question, and one that I've looked in the, in the research literature to answer that question of what's the right time.
Mm-hmm.
And, we haven't published on this, but one of the questions we did ask the patients, we did this about 6 weeks post-active treatment. And we asked them just in a qualitative interview, how did you feel about the timing of it, just to get a better sense? And they all said, yeah, it felt like about the right time. So does that mean 6 weeks is the right time? I don't know. I mean, it wasn't like, it's not like we compared it to some other time point. And then also, of course, anybody that participated in our study was willing to participate in the study. So, it's kind of like a captive sample of people that were happy to do that. So I think part of it is we don't know. I'm sure that clinicians and providers have a sense about that. And there's always probably going to be people that don't, want that at all. But it seems like my sense is that when people start having these needs, even if they don't even realize they have them, that's a good time to get in there and start saying, a lot of people are having these issues, let us know if you have any of these issues. And we have ways to deal with them. So probably not a very clear answer to your question. It's a really good question.
My concern is that we just end up throwing out the whole idea of the care plan because if they're not ready for it or accepting of it at the time. And
Mhm.
so I'd rather us like try to optimize that than just throw it out as a concept because,
Oh,
that's what
absolutely.
I'm a little worried about.
I agree. And, you see all this research saying, well, they're not very effective. Well, I think one of the reasons, maybe they're not effective is it's like so hard to deliver these things when you're in the midst of all, everything else you're trying to get done in the healthcare system. I don't think that means that they're a bad thing. It just means we haven't figured out the delivery of them. And this is one possible option for, you could even deliver this care plan, 6 weeks post. You could do maybe the treatment plan and then, or even give them the survivorship care plan, but really go over it 6 weeks later. Again, like uncoupling it from that end of treatment visit, I think is something that in and of itself could be tested to see, is it more effective? Do people retain more of the information? Do they appreciate more of the information or use it? Yeah, that's a whole other avenue.
Yeah, and I think people talk about the first year after treatment being the hardest, harder than the treatment itself. We hear that all the time. So maybe, but partially because you're disconnected then from the team that's been taking care of you this whole time. So having that touch point, like you finish treatment, but then having relatively soon, but another touch point with them where you can get that information could be useful. But figuring out the timing, I think, is important.
Yeah, I absolutely agree. I wish I had a better answer for you.
Yeah. So another question was, do you find palliative care is misunderstood by cancer patients as if it's equivalent to hospice? And was that discussed at all in any of your in the intervention?
I will say that was not something that we really dealt with at all. I don't know if it was just because it was right when people had finished, could be the timing of it when people had just finished active treatment. So, if they were still in any kind of treatment, we weren't necessarily, including them in the study. It could be just the population that we used.
Great. Someone else asked if in rural communities, religious institutions are often a source of psychosocial support. Is there any way of integrating that into or having the nurse coordinate or in some way make that kind of connection?
Yeah, so that is such a great question. And I think the answer has changed since COVID. So my doctoral student who worked on this study also did her dissertation looking at cancer survivors in rural areas and their resilience and their sources of resilience. And she fully expected that. She was also looking at places. So on the one hand, at least with our population in Southwest Virginia, overwhelmingly people were talked about religion and God and spirituality, but people were not going to church probably because of COVID. But they found that, and at some point during COVID, churches were open. That's just not where they were going. People found spiritual groups, and I think mostly on Facebook groups. So they found chat-based groups that's what people really talked about. And so, I shared this with our supportive care team to say, I don't, because they have spiritual groups for people, but again, you need to be able to connect, over broadband. But I said, people should be maybe suggesting these as well. I'm sorry, that was a study I didn't even cover because she just finished it like a couple months ago. But yeah, the physical place of church did not seem to be where people were going. They were going online, despite the fact that, people were really talking very strongly about needing that spiritual care and support. It's an interesting finding, surprising.
Yeah, that is really interesting. So one more question I'm going to ask. And so how do you think any of these findings would translate to cancer survivors in an either urban or rural, ex-urban setting? Because I think some of these findings are probably, pretty specific to patients in a rural setting, but some, like the idea of a, nurse visit after treatment ends to assess unmet needs could be useful for any cancer survivor, even if they're not in a rural setting.
I mean, I completely agree. I think if we can use telemedicine, we should be using telemedicine. If people don't need to come back in and, deal with the parking and the travel, I mean, certainly in urban areas, where people have, the public transportation, or they have to worry about childcare. I mean, just so many different things, or you're caring for elderly relatives, you just don't feel well. I think that we need to be using telemedicine for this and have it be home-based as much as possible. Of course, there's issues with that, whether or not government's going to allow reimbursing for that,
Right.
but hopefully that will still be reimbursable. But I think absolutely that we should be doing this. I think you can do such a wonderful assessment over telemedicine, and then you're not going to have as many of the, probably the barriers that we had. What I sometimes worry about, though, is we need to make sure that we're getting this to rural people too, so that we don't widen that digital health
Right.
divide that, we always have to think about. So I think absolutely yes, but I'm always looking at the rural people to make sure they're getting what they need.
Yes. And I'm glad that you are, because I think that's really important and I think sometimes overlooked. So thank you so much for your work on that and for sharing it with us today. We really appreciate your time. You did an amazing job of explaining it all, and I'm very grateful to you. And we look forward to sharing this. We will send out a link when we post the webinar, and we will have access to Pam's slides as well. Thank you so much. We really appreciate you. And thank you everyone for joining us today.
Thanks, everybody. I really appreciate the opportunity.